can go ahead.
Thank you. Welcome everyone to Canadian Health Coalition webinar on the Day of Truth and Reconciliation. I'll just talk a little bit about the Canadian Health Coalition. We are a national organization made up of national organizations and individuals who are passionate about universal health care. We represent healthcare workers, churches, seniors, anti-poverty groups, students, and trade unions, and work with health coalitions in the provinces and the territories. I am here today to listen and learn, because without truth, there can be no reconciliation.
Okay, thank you, Pauline. My name is Tracy Glynn, and I'm the National Director of Projects and Operations for the Canadian Health Coalition. And I'm joining you today from the stolen territories of the Worsfold in what is today known as Fredericton. So today, September 30th, the National Truth and Reconciliation Day, is being marked in New Brunswick as an official provincial holiday because CUPE Local 1252, representing more than 9,000 healthcare workers in New Brunswick, were successful in their grievance to have today recognized. So they had actually filed a grievance, and in the decision issued on August 10th, the arbitrator upheld their grievance, ordering the provincial government to recognize today as a holiday for workers. And I think this is an example of how work that we do with Indigenous communities, in solidarity with Indigenous communities, how we are hopefully moving towards truth and reconciliation. CUPE, one of the members of the Canadian Health Coalition, and our coalition stand in solidarity with Indigenous communities across Turtle Island. We can all do better towards our collective goal of ending colonial processes and coming to reconciliation and what our Indigenous friends say, reconciliation. So the Canadian Health Coalition does work to end systemic discrimination in healthcare. And so stay tuned for a future webinar on migrant healthcare and other topics related to ending systemic discrimination in healthcare. So I'm now going to hand it over to our host, Anne Lagacé Dowson.
Hi there. Can you hear me now? Hiya. Bienvenue à ce webinaire sur la décolonisation du système de santé, how to end racism in the healthcare system. I'm speaking to you from Montreal, known as Tiohtià:ke in the Mohawk language. So I'm on the unceded Mohawk territory, the territory of the Haudenosaunee in southern Quebec. And it is the second annual Truth and Reconciliation Day. I can see that there are orange flags flying around Montreal. At 1 o'clock, there is a march organized by the Native Women's Center here in Montreal. So there are many wonderful activities underway, and yet truth and reconciliation is a solemn matter. And in order to address it in all of its facets, especially with regard to healthcare, we have with us a really wonderful guest, Dr. Alika Lafontaine, who is a Métis with Cree background. He's with us in La Prairie in Alberta, not too far from where Pauline is. He's an anesthesiologist and the first Indigenous president of the Canadian Medical Association. He is an extremely accomplished recipient of many awards, and he is active in various facets of promoting and encouraging First Nations, Métis, and Inuit people to enter the medical system. So without any further ado, thank you very much for joining us today, Dr. Lafontaine.
Thanks for having me.
It's really great to meet you, and I congratulate you on this new position, which seems like a logical part of your trajectory from being chosen as the future Prime Minister of Canada by CBC Radio to becoming the CMA, the president of the CMA. I wanted to ask you just to start off, like, one of the things that I think is a great contribution that you have underlined is the importance of storytelling in healthcare. So I wanted you to tell us just a bit about your story off the top.
Yeah, my life has been a series of fortunate events, looking back. And like a lot of people, I ran into barriers at different parts of my life. When I was young, my mom, who's, a first generation immigrant from, the Pacific island of Tonga, she immigrated over to California, then made her way up to Saskatchewan, Canada, after meeting my dad. And then my dad, who grew up in a small farming community in Saskatchewan called Lestock, and, Métis heritage with, Oji-Cree traditions. They'd always taught us about the importance of education. And, in elementary school, I started to have some speech problems, and the school used the tools that were at its disposal to try and address the problem. Eventually, they became very frustrated, let my parents know just how much I wasn't responding. And they kind of put my life on a trajectory where a lot of the dreams of education that my parents had, were really, really dismantled. They more or less told my parents, I'd be lucky to graduate high school. I was never going to university. And that was a time in my life that I I think my parents in particular, they went through a lot of introspection about what I could achieve, and what they wanted to get out of, the things that they were trying to teach me. And I I've since then obviously had a turnaround, right? I mean, I'm a doctor now, and I've had the opportunity to, learn many different things. And, it's interesting how early on in life people project onto you these ideas or caricatures about who you are and what you're going to be.
Mm.
And, sometimes those are rooted in fact, and sometimes they're not. And I was lucky enough to have my parents and a series of mentors that uh, came into my life, that I really stood on their shoulders as I walked towards the place that I'm now. I think sometimes people on the outside look at your life as kind of this straight line towards where you are today, when in reality, it's kind of this zigzag of ups and downs. And I would say that it really for me was just a series of really, really fortunate encounters with people who saw me as more than what I was.
That is really lovely to hear, because I think you're right. There are low points, and then there are, successes and failures. Life is a mixed experience. And I know that you're very active in trying to encourage and reach out to young First Nations people, in Métis and Inuit people, to follow the same path, because you did a chemistry degree, which kind of blows my mind for those people who had a lot of difficulty with chemistry.
Yeah.
You did a chem degree, and then you went to medical
Yeah.
school.
Yeah,
Why were you drawn to that? Why were you drawn to chemistry and then to medicine? Tell us a bit about that.
like a lot of interests, I had people that I looked up to that were in the field.
Mm.
My first science class in STEM was chemistry 101, and I had a professor there who was dean of the college at the time. His name was Nahiz Nuraldin. And Dr. Nuraldin, he saw me at the back of class. He kind of pulled me to the front, you know. And I remember after I wrote my first exam, he walked over and he said, is this the best that you're going to do? I think you can do more. And he really took me under his wing and just made me really believe that I could understand things that to me were very foreign. My parents didn't have a background in, the sciences like STEM, right? My dad had an education degree. He was the first in his family to go on and do a master's. As I mentioned, my mom, she didn't speak English as her first language when she came over to California. I mean, she was a teenager trying to learn English in, a society very, very different than what it was like living in the islands. And, you know, they they were they were watching me go through this experience where I was experiencing something new to them too.
Hmm.
And so it really required people who were inside the field to look at me and give me confidence that, you could do it. I mean, I always came home and my parents always said, do your best, and, we'll love you no matter what, and all these other things. But it's a very different thing to have someone in a position that you want to get to say, I see your future here. And I think when I think about the importance of leadership looking like people, being filled with people who have shared lived experience. I mean, that's one of the unspoken powers of it, is you can say to someone, I know you could do it because I did it too. And when I talk to First Nation, Métis, and Inuit youth, I mean, that's definitely a message that I have. Being a physician and being a leader in medicine is not beyond you. it's a rough path, but it was rough for me too. I mean, that's just kind of the way that it is. And so lean in, you can do it.
So you basically just made the case for mentoring, like,
Mm-hmm.
yeah. And I think a lot of people are, lack that. They come, they're first generation students. They don't, as you said, they
Mm-hmm.
don't have family in the field. They don't have role models, and mentoring is huge. So those of us who are on the call listening to this, I hope that perhaps you'll consider following the example of what Dr. Lafontaine is describing. Just reach out to that kid,
Mm-hmm.
the person who maybe looks a little confused or lost. I think that's really important. So I wondered now, so one of the things that you've talked about working on is racism in the healthcare system. We know
Mm-hmm.
the family of Joyce Echaquan filed a suit this week for damages as a result of her premature death at the Joliette Hospital after enduring incredible verbal and physical neglect and abuse. I'm wondering, what did you think when you heard the story of Joyce Echaquan?
The history of racism in the system is one that's well known to people that experience it, but it's like many things in health. You don't really know unless you are there. And I think what Joyce did in live streaming what ended up being, some of the last moments of her life, it hit a chord in people where they saw for the first time this experience that she had likely gone through many times before, but now it was in front of them. They couldn't ignore it anymore. And I think that's one of the reasons why I look at today, National Day for Truth and Reconciliation as a time for reflection. It's a time for us to move outside of the reality that we live in and into the reality of the people that we may not know what it's like to live in. And the most sad part of the whole live stream for me was that moment at the very end where the person who's providing care was looking into the phone and realized for the first time, all this is being live streamed. And there was this look in their eyes that if you've seen it before, you never forget it. But it's the look of someone who doesn't believe that they did anything wrong. It's the look of someone who doesn't believe that they're going to be in trouble now that people know about this. And I think that's the part of racism that is the most harmful, when we've normalized the treatment of people and the harmful things that they experience to a degree that we just think that it's normal. And you can extend that beyond racism. When a patient comes into an emergency room and they wait 20 hours, we've all started to get used to that. We've gotten used to people moving from, week-long or month-long queues into waiting several years for things that cause incredible pain and suffering to them every single day. And I think that's always the scariest part of seeing where the health system is going when we normalize these very, very abnormal things. And, Joyce sharing that experience, I think was a moment, like many other moments that come out whenever I think the general Canadian population who doesn't have these lived experiences realizes that this stuff is going on, for people to sit back and say to themselves, is this really what we want to accept? Like, is this what we're trying to build? And you can change cultures. There is always hope that people can change the way that they act and the way they interact if they know or feel different things. And that's one of the reasons why I think days like today are so powerful. Like it's an opportunity to really curate, an opportunity for people to rethink, like, what do I believe and how do I treat the people around me?
Yeah, and for those of us who are familiar with that hospital in Joliette, which is very close to the Atikamekw Reserve, that community has been known for a number of years for its discriminatory attitudes towards First Nations. So that live stream was a real revelation, I think, for a lot of people who aren't familiar with with that community. I'm wondering, what would you suggest we do? Here we are, we're the Canadian Health Coalition. You're now the head of the CMA. What are those of us who are allies on this call to do? What would you suggest we consider doing at this point, now that we've come to this new sort of threshold of understanding, or are beginning to better see the legacy of the residential schools, the Indian hospitals, the experimentation that was done on First Nations people in some of those institutions, forced sterilizations. I mean, these are all, they're so disgraceful, so mind-bogglingly terrible.
Mhm.
It's time to move beyond that. So how do we do that? What would you suggest we do?
You know, I've obviously thought a lot about this question over the past couple of decades, and my opinion has changed over the years. You know, I think when you try and create change in the system, you believe that if you break it, or if you start enough fires where it burns down, things will be better. But the question is what comes after. And the truth is, even when you break parts of the system, the culture is still there. And so it's different faces, but the same problem. Right. And I don't just mean this with racism. I also mean it with the way that we currently look at patient care and worker burnout, and, you know, the burdens that we're placing on the shoulders of people throughout the system, patients, their families, healthcare providers, especially the frontline, in kind of carrying the weight of what we're going through right now. I think that starts with truth, but I think truth only changes people if they realize that the truths they believe actually drive the actions and the way that they see themselves. Now, I've started to talk a lot about, you know, self-identity in medicine, in particular, how physicians see themselves. You know, the burnout that providers are experiencing right now, to a great degree, is because we feel like we have to sacrifice all the parts of ourselves in order to shore up these cracks. You know, being labeled healthcare heroes is always a double-edged sword, because heroes are sacrificed in stories. And so we've normalized the fact that, you know, people are burned out because that's just the way that things are, when in reality, that probably isn't the way that things are. We've just designed systems to provide those outputs, you know. And if we lean into the truth, we eventually get to the point where we start to realize that, you know, our shared history, the things that we take for granted day to day, you know, they are a result of decades of decision making. You know, in the case of residential schools, you know, hundreds of years of decision making and treatment of people that have kind of led us to where we are today. And that's a painful process, you know, for a physician to realize that their actions when it comes to racism are harming the people that they're supposed to be treating. That directly attacks the self-image that we have often as frontline providers, that we're there doing good work. You know, that what we do is implicitly positive for the people that we work with. And confronting the history of Canada and all the things that you mentioned, residential schools, Indian hospitals, medical experimentation, forced sterilization, you know, these are layers that we're peeling back on our own Canadian self-identity. And it changes the way that we see ourselves. You know, it's a challenge to not flatten the people around us into two-dimensional characters. You are just this, you know. And I think that's really what people are pushing back at these days. You know, the polarization that you see is really a flattening of people into, you know, these labels that attach certain characteristics, when in reality people are complex. You know, they're three-dimensional characters. They do both good and bad. The person who is racist to an Indigenous patient may treat the next patient like the best way ever. You know, now how do you consolidate? And this is why the word reconciliation is so important after truth, is because reconciliation is a reforming. It's like pulling back together those fragments, you know, that separate us from each other. You know, and it's really forming a new Canadian identity that's really based in the shared history that we all have. You know, residential schools led to many things that impact non-Indigenous people. You know, forced sterilizations impact, you know, everybody who was involved in, you know, the procedures, but it also impacts the people who lived in the area, and, you know, how society kind of grew and developed. And so, you know, finding your place in that story, I think is really, really important. And so how do you get to that point where we can start to mitigate and solve some of these things? It's the truth. It's, you know, looking at your own self-identity and creating a new story, you know, realizing that your position in it has shifted, but that doesn't mean that there's not hope for good things that can come after.
That's a very conciliatory answer to a very difficult and painful question, in a sense, because the legacy is so heavy. And today, part of what we're doing is remembering the premature deaths, unfair treatment of hundreds, if not thousands, of children, starting with the bodies we discovered in the residential school on the site of the school in Kamloops. Like the idea that the children were kidnapped in that way and then deliberately, neglected and worse. I mean, it's so painful that I really appreciate your response and the positive nature of it. I wonder, sorry, go ahead.
Yeah, this reminds me of a quote that I've shared from an elder that I've worked with named Ted Cusans. He's from Kisakus First Nation. And, one of the things that he always reminds me is that people are ready to share their trauma. It's just, we're not ready to hear it, and, the weight of this day, the weight of those stories of, the children that never came home, unmarked burials, the breadth of it, how common it was across the country, the fact that they built cemeteries adjacent to schools. I mean, that's very abnormal to have that as part of your planning. I think we have to prepare ourselves in order to receive some of that trauma. We often worry so much about what's going to happen to us if we learn truth about things that are going on. This happens especially with racism within medical environments. People are very concerned. Well, people come out and we address racism. Well, what does that mean for my working? What does that mean for us as a culture? Are we, inherently bad people then? How is that going to affect my, professional status, my ability to work, like all these other things? And I think we really need to step back and realize we're not at that point right now. We're so far before that point where we have to worry about those types of consequences. What people who hold these stories and experiences want, I think, is they want to be able to express them and have them accepted, not interrogated. They want their lived experience to have people reflect and change. And then with that, they actually want the harm to stop. I've always found it really interesting that when patients experience harm within the healthcare system, the system is really geared up to push back at those stories and invalidate them through the processes that we have, because it's really afraid of the risk of what happens if those stories are true. But most people aren't very risky, to tell you the truth. People just want the harm to stop. And we push people to this stage like Joyce's family, where they sometimes feel like the only way to get answers and the only way to see change is by launching these legal lawsuits. And I'm not going to project onto the family like what they want out of this. Sometimes these types of suits are a part of healing for those families. And if that is what it is, then I mean, they're justified in doing it. And I think that patients should pursue things that make them feel whole again. But, the system definitely did not support that family in them feeling like the lived experience of, their family member who died, was fully accepted by the system. And the system has yet to really move into that place where it's going to resolve that harm, where they can have confidence that if I come to that place again, I won't experience hostility. I won't experience, lower standards of care that could lead to my disability or death.
It doesn't help matters when you hear the incumbent premier of Quebec, because we're in election mode here. The election's on Monday. The premier of Quebec, François Legault, denying that there's any problem with systemic racism, and then saying on camera, well, the problem at the hospital in Joliette has been dealt with, when that's far from clear. I mean, there's exactly what you described. There's a lot of denial and defensiveness amongst you would think amongst, surprisingly so, amongst people who are in the position to have an influence on the system. I wondered, there's this thing called the Confidence and Supply Agreement between the Liberals and the NDP at the federal level. And you're the head of the Canadian Medical Association. I wonder if you have any thoughts or any ideas about what could be done in the context of that CASA agreement that might address some of the problems you have touched on, and as well as the larger issues of access to things like dental care and pharmacare This is a kind of an unprecedented situation we're in, where there's a chance to improve and build the healthcare system, which your predecessor said was on the verge of collapse, actually, Dr. Catherine Smart. I wonder if you have any thoughts to share with us about the CASA.
Yeah, so first, I agree 100% with Dr. Smart. You know, I think when you have waiting times how they are, when people can't access, you know, primary care, when you hear stories about people waiting days on end in order to have emergencies dealt with, you know, in hospital, systems are falling apart, you know, and in some places they have collapsed or are near collapse. Health is inherently political, but I'll try and stay out of the politics of the agreement and instead focus on the opportunities. You know, we have this system that's siloed. You know, we not only silo ourselves across 13 provincial territorial systems, but we also silo our problems within those silos. You know, somehow the medications that people take are separate from the care that they receive, which is then separate from the health human resources that we need to draw on, which is then separate from all of these other things. And I think we're at a time in the healthcare system where we are realizing more and more that the status quos that we've come to accept with these silos just don't work for us anymore. They don't address the challenges that we have. And I think the questions of, say, pharmacare are definitely complex, but it opens up a conversation around the care that we need to provide in the system, and what does healthcare in Canada actually mean? You know, we went through, you know, our own records, and you know, we came across, you know, an interesting data point that the federal government and the provinces haven't sat down and had a real discussion on how to restructure healthcare since, you know, the 1970s. So we're now in a state where we have to rethink what team-based care actually means. I'll tell you, team-based care and how it's expressed right now through provincial territorial government seems to be switching out the highest cost provider with the lowest cost, which is not what team-based care is, right? It's about people getting the right care at the right time from the right person. And, you know, I think physicians are best suited to deal with specific situations. And so are nurses. You know, we're not trained the same way, right? I know in Ontario, there was that call to have, you know, physicians and trainees fill nursing spots. That's inappropriate, in my opinion. You know, we are not trained in similar ways. We do not have the same sorts of skill sets. And, you know, team-based care will we respect what people do well, and then we help people get the care they need in a way that they get what they need at the time of the encounter. I think is really the thought that we can rebuild around. And medication and access to medication is really important, but then there's other aspects to that as well. When I prescribe medication to a patient, what do I know from research? I know that patients often don't fill their prescriptions, or when they do fill their prescriptions, they take their medication for a time and then they stop, or they take it incorrectly, or they take it up to a period of time and then don't finish the whole prescription because of side effects or other things, which never get fed back into the system. And so there's a lot of complexity that goes along with how to operationalize something like pharmacare. But the really exciting thing about where we are right now is we can actually have these discussions, because for the first time we're realizing that the place that we're at, it's not the place that we need to be in order to create the future of what Medicare could be.
I wonder, Pauline Worsfold, RN, inserted a comment on the chat. Did you want to jump in, Pauline?
Well, sure. You know me, I'm never lost for words. And
I know.
I also work closely with a lot of anesthesiologists because I'm a recovery room nurse. But my comment in the chat was the system may be on the verge of collapse, and indeed have collapsed in certain areas, but privatization is definitely not the answer. If we think we have a problem with what we've got now, oh, let's forget about it, because who seriously can pay for whatever procedure that they need to have done, or pay for their doctor's visits on top of their medication? Privatization is not the answer. And if the federal government and the provincial governments want to funnel, millions of dollars into the healthcare system. It needs to be in the public healthcare system where its care delivery is based on need, not greed.
I think we sometimes take these economic frames, but only partially apply them. So I agree with you. I don't think private care is the answer. I think the approach of private care is actually part of the reason why we're at where we're at right now. So the scariest part of private care for me is fragmentation. And what do we know from fragmentation that's happened across not just healthcare, but elsewhere? Suddenly we can't get access to the consumables that we need because we no longer produce them in the country. With vaccine production over the past couple of years, we dismantled our ability to build drugs within Canada because we're now outsourcing them to other countries. And we ran into major problems as a result of that. And we were very, very lucky that we had, partners that were willing to help us despite, needing the resources for themselves. Global supply chains, they cost less until they don't. A big reason for inflation is because we have this fragmentation. Economic theories like risk adjusted pools. I mean, we have potentially the most efficient health system in the world because everyone's in the same pool.
Right.
But we don't lean into that seamless experience for people. And because I think we stay in our silos and we don't consider where it does make sense for us to work together. The CMA has been focused on things like pan-Canadian licensure and particularly, the registration that goes along with that. Not necessarily the self-regulation, which I think is really important to maintain at a provincial and territorial level. But, if you had a seamless registration of people, you then could start to create national health human resource plans. You can combine with training institutions that, create new providers. You can create these pathways into the system for people who practice internationally, instead of them having to learn 13 different systems and 13 different requirements for, materials that they have to produce. You could have a centralized system where that becomes much more straightforward. And so, I think the discussions, like we talk superficially sometimes about very, very deep things, and obviously, like you've thought deeply about this, Pauline, but we get drawn into these conversations politically and nationally that don't actually look at what the root problems are. We will not solve our problem with fragmentation with more fragmentation.
And I just want to mention again, in the context of the Quebec election, there's been a proposal floated to build up to 10 private hospitals in Quebec, as if that's going to solve, long waits and emerges and on gurneys in the hallway and sitting in ambulances in the parking lot. Anyway, I'm super glad to hear you say that. I think we should cut away to Tracy, who's going to present us with a couple of questions from the audience that have popped up in the chat. Are you with us, Tracy?
Yeah, I'm here.
Okay.
The first question, and please, participants, please post your questions in the chat. The first question that appeared is from Esther Chow, who's asking how do you think the current healthcare system can encourage Indigenous ways of healing?
Yeah, so that's a really great question. I think part of that is realizing that Indigenous ways of healing have already been integrated, but we label them something different. If you look at the history of Canada when settlers first came to Canada, particularly those that came from Europe, European medicine was still, for humors. It was, let's bleed you out if you have a problem. But they came to a place where poultices, ingestibles, people were harvesting medicine at peak potency. Half the drugs I use for anesthesia actually came from natural sources. Maslow's hierarchy of needs, Maslow's hierarchy of needs was taken from, Blackfoot teachings. So there is this integration already of Indigenous ways of healing. And I think if we start to refocus on whether or not things work versus, this to me, a very arbitrary division, and relabeling of these things, and start to learn the history of, where our medicines came from, where, our theories came from, where, our ways of thinking about patients came from, I think we'd realize that Indigenous teachings are a part of what we do. It's just we don't give honor to where they come from. And once you start to learn, I think, about how much we've actually learned already from Indigenous peoples. It changes the frame for how you bring communities into that knowledge. You know, if I have a patient who has chronic pain and, you know, they go to a traditional healer and they manage their chronic pain, like that's a fantastic thing. Why would I be disappointed in that? And what we need to do as providers who, you know, promote the inclusion of traditional medicine practices into health is just remind people like these things work, you know, and share our own stories about how they work, and find ways that we can, you know, work with patients and providers in the community to, you know, really respect what they bring to the table.
Tracy, can I ask you to maybe
Mhm.
put together a little bundle of questions that we can throw at Dr. Lafontaine, because we're coming up to the end of our session today, which I'm so sorry to say. Like, it's wonderful to meet you in this way on this webinar, and I thank the staff at the CMA and you for joining us. So Tracy, do you have a couple more questions we can address?
Yeah, so the next question is from Ivy Bourgeois. Ivy says, Alika, Ivy Bourgeois here, can you speak to the issue of how we have no data on the Indigenous identity of any health providers, doctors, nurses, pharmacists, etc., which means we cannot say whether we are advancing the TRC calls for action, but this does raise issues of Indigenous data sovereignty. Do you have any suggestions as to how we could address this issue respectfully?
Mhm. So I 100% agree with you that the types of data sets we have are not detailed enough to know whether or not what we're doing is working. And so 100% I agree we have to figure it out. I would say just from a more system level, there is an evolution happening with data where we're rethinking whether or not this custodian approach to data, where you have a third party institution hold that data, is really the direction we'll go in the future. You know, I think with new types of technology like blockchain being used in you know, financial applications and otherwise, you're moving more to a real-time consent type way. You know, and I think at the core of sovereignty is, are people getting value out of the data that's being collected and how it's being applied? You know, and I think if you only focus on kind of the custodian frame, the question becomes who should hold it, when that's actually the wrong question. I think the question is, how do the people whose data is within that database get value out of its application and use? And I think that's actually a universal question that we're trying to work through, not just for Indigenous peoples, but also just general patients. You know, your information is caught within a database within, you know, a health region, and people want to use it to, you know, create synthetic data for different applications, or, you know, non-synthetic data that has your personal identifying information in order for other things. You know, I think we have to get to a point where we can actually ask people these questions and let them make their own choices. I think the future is consent-based data management instead of custodial, but that's a whole different seminar, I think.
Is that a file that the CMA is working on actively at the moment?
You know, the CMA is looking at things that can actively impact the now. So, you know, you probably can see from what I've been speaking about, you know, health human resources, decreasing the administrative burden on frontline providers, virtual care, pan-Canadian licensure, you know, the mental health of our workforce, aging with dignity, you know, climate change. These are all things that we think that there's a huge opportunity to push forward in the near future. But there are a lot of priorities that we discuss behind closed doors. And, you know, the great thing about being in a position like this is I get to learn a lot of things about a lot of different issues, and then work with the CMA and our partners to push them forward and kind of move that dial. And I think we can make breakthroughs this year. I really believe that we're at a point in time where something is going to change, and that one thing that changes it might change everything.
It's a one-year mandate, the presidency?
Yeah, it's a 1-year mandate. But one of the things that I hope people see is the transition between me and Dr. Smart was much more direct. And, you know, I expect between me and Dr. Ross, who's our current president-elect, will be similar, you know, making sure that we focus on the things that we know can have an impact is extremely important in positions like this. And I think people can see the consistency from the CMA in this regard.
Tracy, any further questions?
We have a couple more questions. Maybe I'll package these two together. So Donna Wells asks, what are your thoughts on physician assistants becoming a part of the healthcare team and accepted in all provinces as a way to increase access to care? And then the second question is from Catherine Doucette. What can citizens do to counter provincial plans to privatize healthcare? In other words, how do we bring to light and counter how these plans that violate the Canada Health Act and the principles of public administration, comprehensiveness, portability, accessibility, and universality?
Mm-hmm. Yeah, so I think the physician assistant question is really, really great. There's obviously a role for PAs in the work that we do, but once again, it's moving beyond the frame of substitution to team-based care. So a physician assistant is not a physician. A physician assistant is not a nurse. And so you can have the same expectations for certain roles within that team-based care to be filled. And I don't think a PA being a direct access in the way that you'd come to a physician with abdominal pain that's not yet diagnosed is a direction that we should go, right? In the same way that nurse practitioners, they get certain skill sets that they develop in areas like chronic pain or obstetrics. We had a couple of nurse practitioners that actually ran the NICU when I was training in Saskatchewan, and they functioned at the same level as fellows, that were neonatologists. And so, you can have people who are not doctors doing brilliant work within the system, but the question is who do you go to first, and then how do you get categorized into places where those team members can do their best work? I think there's a big part of PAs that we don't necessarily focus on, and that's creating more time for persons to do non-administrative, for them to do administrative tasks, so people can then focus on clinical care. We have an enormous burden on frontline providers, nurses, physicians, everyone else who's on the front line, where they do a lot of things that have little to do with direct patient care. We did a study that obviously looked at physicians, but for physicians, 2 to 3 hours per day is spent on administration. Imagine if that could be redirected to actually seeing patients again. And I think that's a role that PAs can fill, but we really have to be more nuanced in how we create this team-based care, or else we're going to be sucked into that narrative of how do we replace the most costly part of the system. And at times that could be a physician, at times that could be a nurse, at times that'll be someone else, with someone who is less expensive. And I think we're going to just run into the same problems if we continue with that frame.
And what about the question related to privatization?
Yeah, so how do we confront this discussion? And I think it's actually changing what the question is, right? So the question is will privatization solve our problems? I think that's the actual question. And the truth is that it won't. If we had a system where you could spin off, something that was self-enclosed, I think a private option would work well. Like you look at something like Schultes, where they do inguinal hernia repairs. They have a great system where people get high quality care, but that's not most of medicine. You will never find a private institution that's incentivized to provide end-to-end care for something like a bowel resection for cancer. There's hundreds of people that need to touch that patient. There are many, many specialties that are involved. It will never be cost effective for a company to create an end-to-end experience for that. And that's the hard part about medicine, and honestly, the harder part of having this discussion about privatization. It's just not a tool that will solve our complex problems. Where we need to lean in is how do we get the seamless experience when you move within your province or place to place across provinces? How do we get information shared? We still have electronic medical record systems where hospitals don't talk to each other. I have Fort St. John that's an hour and a half away from me in Grande Prairie. They cross that border for certain procedures. We repeat all of the blood work and all of the imaging because the systems don't talk to each other. And so there's an enormous burden that's placed on patients to duplicate and repeat care. And there's an enormous weight that's put on people within the system to do things that we know are redundant because our systems are not designed to be seamless. The future of medicine and the solutions that I think we need to look at are how can we create these collaborations across these silos. And in my opinion, and I think from the position of the CMA, like the group that's best equipped to do that is the public system. because the private market will never be incentivized to figure out this big problem. And that really is the big question, is whether or not privatization will solve our problems. And I don't think it will.
Dr. Alika Lafontaine, what are you going to be doing today after we're finished talking?
There's a walk that's happening later today with the Friendship Center. There's a lunch that I think I might be able to make with the kids. I've used last year to have some conversations with my 4 kids about the history of residential schools. We talked about medicine, we talked about racism, and in medicine, I have a 14-year-old now. She's asking some pretty insightful questions. She wants to learn about her place in the world, and it's a time to reflect. And I have my own stories in my family that are painful. I know that Indigenous people across the country have mixed feelings sometimes about today, because it's a time where they actually revisit a lot of those memories. But working through Canadian history, I think, is really important for us all to do, both publicly and in our own private lives. And I hope that my kids can come to the realization of where they fit in Canadian society as, an Indigenous person living in Canada. Same way as I hope we can get there with the colleagues that I work with and the people who are at the webinar. And I have a lot of hope that will happen.
It's really wonderful to meet you at the beginning of your mandate. Perhaps we can make a rendezvous with you to talk to you at the end of your mandate in about a year's time.
Yeah, I would love to do that. A year-long opportunity to make a change, I think, is in the grand scheme of history, is very effervescent. But if we can move the dial and move things forward, a lot of our challenges were decades in the making, and there's been years of work to try and solve them, and hopefully we can bring something home for the people that need it.
Thank you very much for joining us today. And I want to thank your colleagues at the CMA for helping us reach you and book this, especially Ivy, who's been super helpful. And I'm going to ask Pauline Worsfold, president of the Canadian Health Coalition, and on behalf of the board and the staff, to close today's webinar off. And thank you once again, miigwech. Merci à tous et à toutes. And I'm going to hand things over to Pauline to close.
Thank you, Anne. And thank you, Dr. Alika Lafontaine, and the staff at the Canadian Health Coalition for making this webinar possible as well, on a very special day indeed. I opened today and was neglectful to give thanks to the land that I reside and work on as Treaty 6 territory here in Edmonton. And I am a proud registered nurse and work closely, as I said, with anesthesiologists at a large hospital here in Edmonton. In fact, I'm going to work tonight on night shift. And so I will carry with me the discussion. I will carry it in my heart, and I will, internalize what I heard today. I will move forward with the truth and reconciliation recommendations in my mind, with my care delivery at the bedside, with my interactions throughout my life. And I want to say that without truth, there can be no reconciliation. So once again, thank you to Dr. Lafontaine for sharing his time, his wonderful mind, and his outlook, talking about hope quite a bit, and which fits nicely into the Canadian Health Coalition. We have a Health and Hope campaign that we're kicking off, and hope to achieve pharmacare and many other projects over the next 3 years. And so stay tuned, and I look forward to working with you. Dr. Lafontaine, don't hesitate to use the CHC as a resource for your tenancy in as the president of the CMA. I look forward to working with you. Over to you, Tracy.
Thanks, Pauline. And thank you, Dr. Lafontaine. Yeah, as Pauline said, I'm also going to carry this with me today. I'm on my way to a ceremony where a sacred fire is being lit, and with the Worsfold peoples here. So thank you so much. And thank you everyone who
On the
participated.
call.
Yeah.
Yeah. I should say, I just want to close by saying thank you to the over 200 registrants on today's webinar. It's very wonderful that you were able to join us. And I really, in closing, thank you very much, Dr. Lafontaine. Much to think about and much hope for the future. Merci à tous. Have a great day of truth and reconciliation. Merci.